Good evening, everyone. And I think we can crack on with the topic for now. So my name is Dr. Eva. I've previously done a few sessions, so I think a few people might know me, but if not, yes, I am currently working at St. George's Hospital. And today my topic would be respiratory failures and ABGs. I wouldn't be going into ABGs too much into detail because I was told that we previously had a session on ABGs about a year back, I think, if I'm not wrong, and it's still available on the platform. So you can always look into that particular webinar to get ABGs into detail. I'll be concentrating more on the respiratory failure side. A quick thing about Bite Medicine is that, yeah, we have a question bank as well as live webinars. Question bank is all based on a single best answer. So, and it goes throughout the topic, starting from what the topic is, how would you diagnose it, investigations, treatment, and everything else that you need to know about a particular topic. We also have online textbooks that are written by our in-house doctors. So they're not really textbooky. It's much easier to concentrate that way. Gives you an idea of how to approach each topic as well. Coming back to the topic that we have in hand. So today I'll be covering the types of respiratory failure, what is ALI and ARDS as well, how do you differentiate between the two, how do you diagnose them, investigations that you need to do for respiratory failure, and that's where we get into ABG a bit, and then further treatment options. So a quick recap of just what the respiratory system is. I don't think we need to go into so much detail, just that coming down from the trachea, going down into the main bronchi and into the right and left lung. Your right lung has 3 lobes with 2 fissures, the horizontal fissure and the oblique fissure, dividing the lung into the superior, middle, and inferior lobe. And you've got the left lung, which is a bit smaller than the right one, and we've got 2 lobes over there and only 1 fissure, which is the oblique fissure. Anatomically looking, the lungs end at the sternal border at around rib 4. At the mid-clavicular line, it's at 6, and the mid-axillary line is 8, and posterior at the vertebral is 10. So you just roughly need to remember it as 6, 8, and 10 going back. And obviously we've got the pleura around it, and that is 2 ribs more than that. So that would be 8, 10, and 12. This is just like for you to remember, because a lot of the exams that you might be attending in the future does have this question, and it's always good to keep that in mind. And yeah, so we've got the bronchi, which comes down from the bronchioles, and alveoli, which is the main thing that we need to look at, because that's where all of the gaseous exchange happens. And functions of the respiratory system, obviously oxygenation, so that we get enough oxygen for the body, carbon dioxide elimination, pH balance, because we know if too much of carbon dioxide is left in the body, it can form carbonic acid, which is H2CO3 right here, and which divides into H plus and HCO3. So if you have too much of H plus ions in the body, that can decrease your pH and cause acidosis in the body. And if you have too less of this H plus ions, then your pH increases, and that causes alkalosis. So the lung is one of the main organs that helps balance your pH in the body. And it's much more faster acting than your kidneys, because respiration is actively taking place. So it's much more faster than the kidneys. So compensation or changes in the pH first happen in the lung more than the kidneys. That is something that you can keep in mind, so that when you read ABGs, it's much more easier to interpret. Just know that the lungs are much more faster acting than your kidneys. So it's better to take a look at the PO2, PCO2 first. And ACE production, your angiotensin converting hormone, which we're not going into the details for today. And respiratory failure. So what is seen as respiratory failure is impaired pulmonary gaseous exchange with or without the presence of hypocapnia. So oxygenation gets impaired, which leads to hypoxemia. And hypoxemia is not just a simple saturation drops, which you see on the patient. You would have to have an ABG to diagnose your hypoxia, which gives you the partial pressure of oxygen. Your normal partial pressure of oxygen is 10 to 14, and anything less than 10 is quite significant. Anything less than 8 is even more significant. At least that's what I keep in mind when I treat someone. Carbon dioxide elimination, 4.5 to 6 is what I keep in mind for my range. I think some people do believe that it's 6.5, 6.3. I'm not exactly sure of that value at the moment, but 4.5 to 6 is what I keep in mind. And anything after 6 is something that is alarming for me. And coming to the alveolar exchange, we've got deoxygenated blood coming in through the pulmonary arteries, going in contact with the alveoli and the lung parenchyma. We've got the cells over here, and of course the inhaled air, and we've got basic carbon dioxide going out and oxygen coming into the blood, and your blood getting oxygenated and going to the rest of your body through these pulmonary veins, which go into the heart and then gets pumped even further. So types of respiratory failure, yes, most people know as type 1 and type 2, but I was recently going through some articles under Cleveland Clinic, which said that there was a type 3 and type 4 of respiratory failure as well. Though I don't think we clinically diagnose it so often because we still follow the type 1, type 2 of respiratory failures. Type 1, yes, is hypoxemic respiratory failure, which signifies that there is only hypoxemia without the presence of hypercapnia, which is there is no increase in the partial pressure of carbon dioxide. Type 2 is hypercapnic respiratory failure, indicating that there is hypoxemia as well as increased partial pressure of carbon dioxide, which is hypercapnia. So, which means that your partial pressure of CO2 would be more than 6, in which case. Type 3 is perioperative respiratory failure, is mainly seen in surgical patients, could be intraoperative, could be immediately post-operative. So any drop in oxygen or buildup of carbon dioxide around this period is considered perioperative respiratory failure. It does overlap on the type 1 and type 2. It's just that perioperative respiratory failure is seen so commonly. They've decided to put it as a separate type 3. And shock related is mainly because of circulatory failure, because of cardiogenic or hypovolemic shock, in which case perfusion to the lungs get compromised, and thereby we have respiratory failure. So type 1 respiratory failure, yes, is difficulty in the gaseous exchange. I do sometimes, at least when I was a student, I did get quite confused of the causes for respiratory failure, in which case, so I always told myself that type 1 respiratory failure is more on the alveolar and the capillary level. Type 2 is more on the bronchogenic level, at least the bigger picture. This was more on the microscopic level is what I told myself, at least. So partial pressure of oxygen, in which case, at least in type 1 respiratory failure, is less than 8. 10 to 14 is normal, 8 to 10 is a bit okay. I guess we can give him on oxygen and see how the patient recovers, but less than 8 becomes a respiratory failure. Causes, like I said, I keep it in my mind as alveolar level. So ventricular perfusion mismatch is the most common cause for type 1 respiratory failure. So we've got pulmonary embolism, emphysema, pneumonia, ARDS, pulmonary edema, right-left shunt, which could be both anatomic and congenital, and high altitude. I'll go into the details of each of these. So when it comes to ventricular perfusion mismatch, is basically there's something wrong with the both the oxygenation as well as there's something wrong with the perfusion of the blood. So when it comes to pulmonary embolism, you've got a clot which has reduced the blood supply to a part of the lung, which means that part of the lung is not getting the blood supply it needs. Thereby, carbon dioxide is not going into that area, nor is oxygen, the gaseous exchange is not happening. Thereby, oxygen is not picked up by the blood because there's no blood going into that area. So it's not picked up by the blood, and thereby you have hypoxemia in those states. Emphysema is also a bit of an imbalance, in which case, though the lungs have gone into a bit of dilation, all the parts of the lung have not received the perfusion that they need to be getting, and thereby the oxygen transfer doesn't happen. Thereby there is a mismatch in the VQ level. Pneumonia, ARDS, and pulmonary edema are all something that happens in the lung parenchyma, in which if you look at the picture before this, you can see that these parenchymal cells actually get affected in pneumonia, ARDS, and pulmonary edema. Thereby, the gaseous exchange gets obstructed in a way and doesn't happen like it should be happening. Right to left shunt is when there is a mixing of oxygenated and deoxygenated blood. Obviously, there are some anatomical reasons for it, some congenital reasons as well. Anatomical is something that happens for everyone. I think it's less than 2% in a normal person. And it's basically because your bronchi, your bronchioli also get blood supply, but then gaseous exchange does not happen in these areas. So that part is considered almost like a dead space where gaseous exchange does not take place. So that is so you've got deoxygenated blood coming in and oxygenated blood going out, deoxygenated blood going out again because oxygenation does not take place. So that is considered an anatomic shunt in the body. And congenital ones, we've got tetralogy of Fallot and even ductus arteriosus, where there's mixing of blood, basically, of deoxygenated and oxygenated blood. High altitude is basically because the oxygen concentration decreases as the altitude increases. And there is also localized vasoconstriction, again, causing a VQ mismatch in which level. Type 2 respiratory failure is when there is a difficulty in ventilation, yes, mainly seen on the bronchogenic level or on the chest level. That's what like I said, it's more on a macroscopic level rather than a microscopic level. Type 1 is is like more of the microscopic level. So partial pressure of oxygen is less than 8. And in addition to that, we've also got that the partial pressure of carbon dioxide is more than 6, indicating that carbon dioxide is building up in the body and is not leaving the body or is not being sent out by the lungs. So causes, we've got COPD and asthma. Both of them are restrictive in nature. So they restrict the exhaled air from going out, keeping it in, and thereby carbon dioxide starts building up in the body. Neuromuscular disorders, we've got myasthenia gravis or Lambert-Eaton syndrome, all of these, or disorders that weaken the muscles of the chest, thereby your diaphragm, your intercostal muscles are not actively taking part in respiration. Thereby, they don't contract like they should be contracting to send out all the carbon dioxide out, thereby causing carbon dioxide retention. Chest wall defects, mainly that I've seen, are secondary to trauma. I've got rib fractures or flail chest, all of which also contributes to this. Severe ARDS. ARDS, if it's there for a long time or a chronic period, also causes constriction of the bronchioles, which end up having retention of CO2. Opiate overdose causes respiratory depression if you give too much of morphine, so can reduce the respiratory rate, thereby carbon dioxide does not get flushed out, thereby you start retaining it. So all of these would be considered as type 2 respiratory failure. Type 3, perioperative respiratory failure, like I said, it does overlap on type 1 and type 2 a bit, could be seen as anesthesia complications. Suppose you have a high epidural, or if you have too much of sedation or too much of the paralytic drugs, all of that could result in respiratory failure as well. Inadequate pain management is something that I've seen more commonly, because each person reacts differently to different painkillers. So the painkiller that you would have given might not be adequate for the patient, and they would not have adequate chest pain expansion. So they're not actively breathing. They become more conscious of themselves, and they don't take the deep breath that they should be taking post-operatively. And thereby that also causes respiratory failure. And increased secretions and decreased mobility as well. These are all seen as post-operative complications, so all come under type 3. Type 4, I feel, is not a problem with the lung in itself. It's more of a shock-related situation where there's cardiogenic and hypovolemic shock. So coming to a clinical scenario that I've got today, we've got a 65-year-old man with a history of smoking and is in the post-operative ward after an emergency cholecystectomy. On post-op day 3, he's still actively monitored in HDU for suspicion of a bile leak, as the surgery was quite complicated. Drain appears clear so far. However, he is noted to have saturation drops occasionally on day 3, and on day 4 is on constant need for oxygen at about 5 liters. So approaching the patient, obviously anyone would think of what the possible causes of a desaturation in a post-operative patient would be. And especially if you're aware of the CRISP protocol, which you apply for surgical patients, post-surgical patients, you would be applying that. So you follow the whole CRISP protocol of A to E approach, and then move on to look into your drugs or your post-operative notes. You'll go through your operation instructions to see if there were, and you also go through your operation notes to see if there was any complication. So you basically follow the whole CRISP protocol in a post-surgical patient. And then you think of possible causes that can be the reason for his desaturation. So you've got pneumonia, it's day 4. Possibly he could have aspirated as well. He could be having an NG tube inside. He could be not taking, might not be fully conscious, or could be drowsy, could not be, probably is not swallowing as strong as he should be. Could have atelectasis, especially if he hasn't moved since the surgery. Could have pulmonary embolism as well, could be a COPD, which he had preoperatively, but then a lot of patients, especially patients who have been smoking for a long time, they don't actually diagnose themselves or go to a GP to have a follow-up to know that he's got COPD inside. So sometimes we get to know about it only when they come for the operation. So they won't have the regular preoperative preparation that they should have needed for a COPD patient. And the other causes could be like a pulmonary edema, especially if there is a secondary cardiac cause for the desaturation. And in the scenario that I had provided, there was also a history of cholecystectomy, indicating that there could be a possible bile leak leading to acute pancreatitis, causing the ARDS in his lungs. And post-operative pain management could have been inadequate. And like I said, opiate overdose, that's both the spectrums. It could be inadequate painkillers or too much of painkillers. So this is what I would at least be thinking of if I was called to see a patient who is desaturating in the ward. And I think everyone should roughly have an idea of how to approach a patient and think of differentials so that they have all the investigations in mind that they need to be asking for. Investigations. So I've only written the basic investigations that you will be doing ideally. So you've got your routine bloods, which could be just like full blood count, USNEs, your CRPs, serum lactates, and all of the routine bloods that you would be asking. Arterial blood gas, yes, an ECG and echo, just to rule out the cardiac causes that I told you. A chest x-ray, definitely, and a CT chest if the chest x-ray doesn't show anything too significant, or if you suspect pulmonary embolism, then yes, a CTPA. But again, CTPA is not something that you would immediately ask when you arrive on the spot. So you will have to go through the entire presentation to know which would be your more appropriate investigations. And once you've settled that quite a bit, then you will go into your pulmonary function test of spirometry. And so just a little peep into ABGs. On day 3, when you take an ABG, you see that the pH is 7.40, still being maintained. Your PaO2, your partial pressure of oxygen, is slightly lower, is around 8. He's also been desaturating occasionally. So, but his partial pressure of carbon dioxide is 4.5, which is still pretty normal. Bicarb is at 24.6, again normal. 22 to 26 is normal, and so 24.6 is within the normal range. Glucose is slightly elevated, 6.6, sodium 136, potassium 4.4. Lactate is also not too bad. And so at this point, you might not actively intervene for this patient. You might say, yes, he's got a bit of hypoxemia, start him on oxygen, we'll see how he progresses after this. But then day 4, the patient did desaturate quite significantly, and he needed almost 5 liters of oxygen at this state constantly. He wasn't desaturating occasionally anymore. And when you do an ABG at that state, you see that the pH is 7.32, So he's developed acidosis at this. So partial pressure of oxygen is 5.5, partial pressure of carbon dioxide is 7.8, bicarb has come up to 28.7, glucose has come up to 10.4, sodium is 133, potassium is also quite high, lactate is also quite high. If an ABG was given to you as so, obviously we'd have to start with pH. So we see that the pH is 7.32, indicating that the patient has gone into acidosis at the moment. The next thing that I would look at is partial pressure of oxygen and partial pressure of carbon dioxide. Like I said, bicarb does play a significant role, but then the kidneys take time to act. Your lungs are much more proactive. So the partial pressure of oxygen and carbon dioxide will be the ones to change first. So you can see that there's significant hypoxemia. 5.5 is much lesser than our cutoff of 8. So there is hypoxemia, and partial pressure of carbon dioxide is much more than our cutoff of 6. So 7.8 is also quite high, which means that this patient has now developed type 2 respiratory failure. And if you look at the ABG, you can actually almost estimate the reason also that he could have developed this type 2 respiratory failure. You can see that bicarb has come up 28.7. So you've got acidosis, you've got carbon dioxide coming up. So that shows that it's coming to respiratory acidosis. And you see that the bicarb has also come up a little to 28.7, indicating that the kidneys have now started to try to compensate. They're trying to compensate by keeping all the bicarb inside to make up for the acidosis, but it's still not being compensated because the pH is still 7.32, indicating that this is a non-compensated respiratory acidosis, day 4. And if you look at the glucose level, the potassium level, and the lactate level, it shows that it could be a possible septic reason for the acidosis development here. Yeah, so you will have to start treating your hyperkalemia and lactate, follow sepsis 6, in which case, and take it from there. A few chest x-rays that I've got up is a pneumonia one, which you can see on the left side. You can see that there is bilateral pneumonia, lower lobe pneumonia. It's much more clear on the upper lobes, and you can see both sides being quite hazy. ARDS on the other side, the way that we explain it is diffuse, fluffy pulmonary infiltrates throughout the lung. So you can see the difference between a pneumonia X-ray and an ARDS X-ray. An ARDS does look a way more, I can't say ferocious, but a way more aggressive way when it comes to the lungs. So that's how you can see that there are diffuse, fluffy infiltrates. And a CT chest also can be done for pneumonia, and you can see that this one shows right-sided pneumonia. You can see patchy work seen on this side. And this would be a complication of pneumonia, again, picked up on a CT. If the pneumonia is not adequately treated with strong antibiotics, given that maybe the dosage is wrong, or all of this could be complications that rise up. So in which case you've got abscesses forming, you've got pleural effusions foci, and you've got patchy consolidations diffusely. And coming to ALI and ARDS, so it's more of a spectrum of an acute onset lung disorder. This is mainly seen in patients who haven't had prior a lung disorder. So it's seen as an acute onset of less than 7 days and has diffuse fluffy pulmonary infiltrates, like I said on the X-ray. Your pulmonary wedge pressure, so you've got your capillary wedge, which is inserted into the right atrium or into the pulmonary arteries, into the pulmonary arteries, and you see that the wedge pressure should be less than 18 mmHg. If it is more than 18 mmHg, it means that your pulmonary arterial pressure is quite high, which means that your heart is not functioning that too well, which means the reason for your respiratory failure is more of a cardiogenic cause rather than a pulmonary cause, because your pulmonary wedge pressure is higher than 18. If it is less than 18, it means that your heart is actually doing what it should be doing, and it's not compromised, and it's purely the lungs that is actually the reason for this disorder. And ALI is acute lung injury. We've got it's more of hypodiagnosis, I guess you can say. So it's partial pressure of oxygen divided by fraction of inspired oxygen. And it should be less than 40 when you calculate. If it is less than 26.6, then it becomes acute respiratory distress syndrome. So that's how you differentiate. So it's more like a spectrum. You put your normal lungs, acute lung injury, and then ARDS, which is the more extreme version of it. And also we've got a classification that was set up in 2011 from Berlin, called as Berlin's definition of ARDS. Though Europe follows a different value, they calculate their partial pressure oxygen and FiO2 as 300, 200, and 100. I roughly estimate that it's just divided by 10. So 26, less than 26 will be a mild form of the disease. Anything less than 20 will be a moderate, and anything less than 10 will be a severe form of ARDS. And yes, ARDS is very much underdiagnosed most of the time, but it carries a high mortality rate of almost 47%. Management, start by giving oxygen to the patient, obviously. So you've got your nasal cannula, you've got oxygen masks, non-rebreathing masks, and non-invasive ventilation. Nasal cannula, you can give a maximum of 4 liters per minute, and then you switch over to the oxygen mask, which is 5 to 10 liters per minute. And then you've got your non-rebreathing mask, because it has a valve in place. And you've also got your oxygen reservoir, which is more effective than your normal oxygen mask. And then you've got your non-invasive ventilation, which is a continuous PAP, CPAP, and BiPAP. Difference between the two is that, yes, CPAP means that there is a continuous pressure that is being maintained in your lungs throughout your entire cycle of breathing, regardless of it being in the inspiratory cycle or the expiratory cycle. So if you decide that your intrapulmonary pressure should be around 20 is going to be maintained throughout, like for an entire 1 minute, 2 minutes. It has to be maintained at that point. But if it's a BiPAP, you've got a separate inspiratory pressure and an expiratory pressure. Inspiratory pressure, again, you can manually set it to about 20 to 30, or maybe expiratory much lesser at 10, so that all the carbon dioxide comes out. So you've got your CPAP and BiPAP, and it is quite effective for most patients. But the drawbacks that I've seen is that every time the patient is still conscious, so you're still feeding the patient as well. So every time the patient has to take in food, you have to remove that entire tight mask, and it's quite uncomfortable as well because it squishes up your entire face. And I've seen that at least during COVID, patients would be so bad that every time you take off the BiPAP to feed the patient, they would desaturate within seconds. So that was a bit of a controversy, but then they were not fit enough to have invasive ventilation as well. So there was a bit of a conundrum where we couldn't move either way. But yeah, those are some of your non-invasive ventilation. And invasive ventilation is, you've got your volume controlled and pressure monitored one. Volume control is when a particular a particular volume of inspired air is always maintained in your lungs. So you've got your volume control and your SIMV. Volume control is when, suppose you've paralyzed the patient, or you've like fully sedated the patient, or the patient has some neuromuscular disorder where the lungs, the muscles are not actively taking part in ventilation. Then you've got volume control setting, which entirely takes up the respiration for the patient. You've set up the volume at a particular rate, and you set up the respiratory rate also for the patient. So the entire act of breathing as such is taken over by the machine. So, and also you calculate the volume tidal volume for the patient at about 4 to 6 liters into the body weight of the patient. But the point with STIMV is that you do have a set volume, you do have a set respiratory rate as well, but then it's not fully under the control of the machine. You might have set the respiratory rate at about 15, but you will see that the patient is taking it about 18, which means the patient is awake. The patient can breathe on his own as well. The machine assists him in a way that the volume is maintained. So you might see that the respiratory rate has come up to 18, in which case pressure monitored is under pressure monitored, we have pressure control and pressure support. Pressure control is not something that I've used very commonly, and I'm not too familiar with it. I just know that it's a way of maintaining a particular pressure within the lungs rather than a volume in itself. And yeah, so and that we normally use it for patients who have previous or susceptible for lung injury. Pressure support is when, yes, again, a particular pressure is maintained within the lungs, but then you've got the patient doing all the respiratory effort for it. The respiratory rate is set by the patient. He decides how many breaths he's going to take in a minute. And the only thing that the machine would be doing is that making sure that an adequate amount of pressure is always maintained in the lungs, keeping all the alveoli open and the bronchioles open as well. Your individual settings when it comes to ventilation, we've got the PEEP, which is your peak end expiratory, positive end expiratory pressure. And yes, for a lot of patients, especially with pulmonary edema or atelectasis, we try to keep PEEP a little higher to about 6 to 7 to make sure that all the alveoli remain open. But one should also take care, making sure that if the lungs are healing up and is already fibrosed, and you keep PEEP at a higher end, they could develop pneumothorax, in which case. Tidal volume, like I said, is calculated at 4 to 6 liters per kg of body weight. And assuming that a patient is about 70, we could always keep it at about 450 to 500, depending on how much the patient can tolerate. FiO2, fraction of inspired oxygen, normal room air is always considered 21%. So at least for me, when I follow it, I keep it that each liter is roughly about 4%. So room air would be considered 21%. So my 1 liter would be 24%, and then 28, 32, 36. It makes it easier for calculation, at least in my mind. And then yes, you can always set up the respiratory rate as well. Higher the respiratory rate, you can make sure that the carbon dioxide gets flushed out. So if the patient has hypercapnia, that's a good way to send out all the built up carbon dioxide. And that's about it. If anyone has any questions, yes, please feel free to ask. ABG analysis. Yeah, I did give a heads up in the beginning that I wouldn't be going into the details of ABG because we've got a previous session which was done about a year back, which went into the details of ABG as such. So I've just explained the ABGs that I put up, and I think I explained how you can diagnose respiratory failure as well as possible diagnosis that you can make from the ABGs in itself. It looks like IRDs in pediatrics in the X-ray. Well, let me take a look because I haven't seen. Well, I could be a pediatric patient given that we've got the scapula and the bone formation, but I'm not really sure of the age of the patient. I haven't seen the patient myself, and I did not take the X-ray myself, so. Can you not use high flow as non-invasive? You can use high flow as non-invasive, but then, like I said, it's a very tight compartment, tight aperture on the face of the patient, and that is not really uncomfortable. I mean, that's quite uncomfortable for the patient. But then you do always keep it at about more than 10 liters if you're going for a CPAP or a BiPAP, unless the patient can tolerate even at a lesser oxygen rate. Yeah, but it's very subjective, like how you want to give it for the patient, because it depends on what they can tolerate and what level they need to maintain the saturation as well. So it's a very subjective thing in which case. All right then. If anyone has any other questions, they can ask right now. If not, feel free to put in the questions or mail the questions to the website, and we can pick it up from there. All right then. Thank you.